I'd really like to welcome Lynne Cox from Wellcome Leap from my side of the pond. So I'm very excited to hear more about this.
Right, thank you everybody, and thank you so much Andrew, because he's essentially given the introduction to the principle behind what I'm doing. So I'm a program director of Dynamic Resilience Program, co-funded by Wellcome Leap and Temasek Trust, and we've got 3 years to spend $60 million to really shift the dial on resilience. And try and light this up. So we've heard about ARPA-H, and actually ARPA-H is our little kid sister or brother, because Wellcome Leap has been running since 2020, and it's based on a DARPA model, very much as Andrew has already told you. But this time we're a global ARPA for health. We're a spin out from the Wellcome Trust. They've put a huge amount of money, not quite as much as ARPA-H, but in the high hundreds of millions into looking at funding health programs at scale, building unconventional programs, so high risk, high reward, collaborative global programs, funding them at scale and trying to get results very quickly. And I noticed that Andrew had a little jigsaw with a top right-hand corner square. We work in what's called Pasteur's quadrant. So we support research that is use-inspired, but has a very high basic science content. And the value of that is bringing the world's best researchers together to address a pressing question. And our pressing question is resilience. Why are we focusing on resilience? Well, we've already seen many times today, yesterday, and also Andrew's talk this morning, health deteriorates over age. So increasing age, decreasing health. And then we hit a period, a threshold below which we can no longer look after ourselves and become dependent. And what the majority of biomarkers of aging are measuring is to look at, to measure, and to predict that health detriment over time. But it's not as simple as that. So aging isn't a straight line. It's not a smooth curve. People experience events during their lives. They have accidents, they fall over, they break their hips, they have serious infections. People have to go in for interventions, clinical interventions, such as surgery or cancer treatment. And everyone at some point in their lives will undergo a major psychosocial stress, such as bereavement. These stresses, as we've heard several times, accelerate health deterioration. So it's not a smooth line. It's a very, very bumpy curve as we progress down towards dependency in later life. And we know, and Luigi's talked about this as well, that frailty is a state where essentially we've lost resilience. We've lost the ability to bounce back after those stresses, and which makes us incredibly vulnerable to very poor outcomes after stress events. But it doesn't have to be this way. We know that certain individuals it's very hard, this clicker, actually maintain their health pretty much throughout their life. I mean, we call this, and other people call it, squaring the curve. Essentially, we want to live well all the way through our lives, go to bed, not wake up, we've fallen off the cliff. That's much better than having this gradual deterioration of health as we age. And so this is what resilience looks like. And this is what we want to achieve for everyone in the population. We want to restore resilience in at-risk adults to reduce or prevent frailty progression after those stress events, and reduce or even prevent that loss of independence, so that morbid period, dependent period at the very end of life. And we know it's possible because some people are naturally resilient. So if you look at centenarians, they've lived through 2 world wars, they've lived through multiple pandemics, they have had infections, they've had surgery, they've had falls, but they've bounced back, they've come back to a state of good health. So they are naturally resilient. What can we learn from them that allows us to restore resilience in us? And so we're at the state now where we know we want to achieve resilience. We know that centenarians are resilient, but we actually don't know what resilience is at a cellular or molecular level. And we're pretty much in the dark ages. We're in the sort of like where we didn't know that diabetes was that you could measure diabetes by measuring blood sugar. And we're actually even worse in that state. We're at a state where we don't even know that diabetes is a metabolic disorder and that actually insulin is involved and blood sugar regulation and lipid regulation are involved. We know very, very little about the basis of resilience. But what we do know is that health detriment appears to be associated with frailty factors, and that health resilience is associated with positive factors, good things that happen. And so we can go from a state of physiological function to a state of dysfunction. But what we want to do is make sure that we can actually push the dial back the other way. And what do we need to measure? We don't know at the moment, but there are some clues coming through from the literature. A really beautiful paper came out in 2023 looking at zebrafish resilience. And zebrafish don't like it if you fish them out of their water and then catch them in a net and plop them back in some more water. And some organisms cope pretty well with that stress, some of them don't. And so you can distinguish between resilient and susceptible or vulnerable zebrafish by their behavior following that stress event. But if you take those individuals prior to the stress event and you simply measure their gene expression patterns, they're pretty much indistinguishable. You cannot tell at a steady state level that these individuals are going to be different. What you have to do is impose a stressor. Now, vulnerable or susceptible individuals actually don't really respond very well to those stressors. They show very little changes in their gene expression patterns, whereas resilient individuals completely flip the dial. So gene expression that should, in a basal state is high, goes low, and vice versa. And this is a really big dynamic response to an acute stressor. So we need to be looking at these changes in very short time frames, not over periods of weeks and months, but actually immediately pre and post stress. And interestingly, studies in zebrafish came out with certain pathways that were associated with resilience, including upregulation of immune genes and metabolic homeostasis and neuronal signaling, and a decrease in pathways involved in senescence. So this gives us some clues that it's possible to modulate resilience, or to measure resilience and look at pathways involved. And it's not just in zebrafish, it can be done in humans. And this is a study from the Baltimore hip fracture cohort looking at which markers are predictive of health outcomes after hip fracture. And a very small handful of markers explains 27% of variance in health outcomes after hip fracture. Oh, geez. Sorry. And for instance, TNF-R1 is associated with very poor outcomes following hip fracture, much worse than predicted. So there are markers that can be measured in the blood that predict either poor outcomes, so dysfunction, or positive outcomes, physiological function. So in the Global Dynamic Resilience Program, we're doing exactly what Andrew said. I pitched to Wellcome Leap. They asked me to run a program on resilience, and we have 3 program goals. The first is to look at markers of resilience. And the important thing here is that we want to identify both correlative and causal measures of dynamic resilience that have predictive value to make clinical decisions. So when we look at frailty index, area under the curve, anything between about 0.6 and 0.75, 25% of older adults are not covered by the frailty index. So although it's good, it's not good enough to make clinical decisions. It's good enough for planning a healthcare system, but at the level of the individual, it really doesn't work. So our goal is to increase sensitivity and specificity of markers that actually allow a clinician to say to a patient coming in, as we heard yesterday, yes, you're suitable for really intense chemo, or maybe you're not. What we also want to do is identify these resilience mechanisms and to use mechanistic models to identify interventions in stress testable systems. And our goal is to achieve at least 3 mechanism targeting interventions that improve resilience. And then, and perhaps most importantly, We want to do this with clinical validation. We want to be taken seriously by pharma, by healthcare workers, by the population, and by funders. We want to validate those markers and test those interventions in at-risk human patient groups with a very, very stringent target of reducing frailty progression by 25% in at-risk adults. And we've got 3 years to do this. So we're running all of these things in parallel. And the way that we're doing it is to bring together a global team of performers. So I'm glad all the terminology has already been sorted out. And our performers across 5 continents. We're not in Antarctica, I'm afraid. But we cover 5 continents. We have lead groups and then co-Is within those groups. We're covering geographies, we're covering ethnicities, we're covering socioeconomic position, we're covering all sorts of aspects of human aging, and we're covering multiple areas of human biology. So in terms of biomarkers, what we are trying to do is not just measure that gradual deterioration, that detriment over time. What we want to do is measure the ability to bounce back. And so we're designing experiments whereby we can look in cohorts at pre-stress predictive markers, what happens on a stressor, and then what happens deep mining data from longitudinal cohorts to find out who recovers properly, who recovers back to a lower baseline, who actually deteriorates. And unfortunately, there are individuals after stress events who do so badly they end up dead. So we are looking at deeply phenotyped and biobanked longitudinal cohorts. We heard from Sarah yesterday about how important it is to use longitudinal cohorts. We have clinical history and known outcomes after stress. So we have multiple cohorts within the program. We're looking at some very large, really call it jet lag, or maybe an aging brain. So what we're looking at is cohorts in Norway. We have a massive Japanese centenarian and super centenarian cohort, amazing stuff. We're looking at the difference of genetics and early life environment play in establishing resilience using twins cohorts. We have, and Alexandra Stolzing will be speaking later, a newly recruited prospective a small cohort in Loughborough. We have a brain resilience cohort in Kenya, and then the Rancho Bernardo study that's been running for 50 years. And then we have stressors, falls, fractures, surgery, major infection. Yes, I know. Biomarkers, different modalities of biomarkers, so all the omics plus. And I just very briefly want to show you that we need not just new markers, but we need new tools. We're looking at a different time constant than most markers will look at, and we need continuous measures. So for example, we've got an engineering approach from a group led by Yuxin Liu in Singapore, who are looking at wearable sensors for solid state biomarkers. This was published very recently in Nature Materials, where Yuxin has developed a way of solubilizing solid state molecules on the skin. You don't have to sweat. You can be a sick older adult in an intensive care unit, and you can still pick up markers on the skin that are coming through from blood. And what he's shown is these sensors are suitable for wear on old, frail skin. They don't break the skin, and they have very, very strong correlation between serum concentrations and what's measurable on the skin surface in this continuous, non-invasive way. We also have, this is not new data, it's published data, because obviously this is live and I can't show you.
Thank you so much, Lynne. I'm really, really sorry to cut you off, but we need to make sure we have time for all the speakers. Please do find Lynne amazing program.
Right, can I just show you that? Right, we have these, but we do have clinical validation. So that was going to be the last slide. We have 8 prospective clinical studies across 6 countries, validating, oh geez, this is taking forever, validating the biomarkers, and we have 4 interventional treatments. And I'm so sorry that my brain isn't in gear today, but anyway, watch this space, because we're a year in and we've got some very exciting data coming through.
So much. Really fascinating program, and I'm glad we were able to feature both ARPA-H and Wellcome Leap here today.